Welcome to My Body, My Bump, My Baby, where we help women be empowered, intentional mothers. This podcast is best enjoyed sipping tea or taking a stroll in nature. This podcast is for informational purposes only and should not be substituted for professional psychological or medical advice, diagnoses, or treatment. Always seek the advice of your physician, midwife, or other qualified health provider with any questions about your personal situation, health, or medical condition.
Welcome back to My Body, My Bump, My Baby. Today we are with Dr. Jessika Martin. She is a dentist and tongue tie specialist. She has a special place in my heart because she helped, and I get teary-eyed with this at the very beginning, but she helped my family when my son was born with a tie. Today we are going to be discussing all things tie related for both babies and adults. This is an episode that you will not want to miss. Regardless of whether this is your first or your fifth baby, it is extremely impactful information to have. So without further ado, welcome Jessika. I am so excited to have you on here today. I know we've been talking about this for a little while, so I'm really excited to have you. I would love to give the audience a little bit of background, just a general background about who you are as a human being, but also who you are in your training too.
You betcha. You can't show me emotions.
I am sorry. It happens. It's only makes this podcast better.
Fair enough. Well, I'll talk to you a little bit about who I am as a dentist first. It starts way back. As a kid, my mom, who is my dental assistant in the office, actually, she was a dental assistant when I was a kid too. And I was the worst dental patient. I was scared to death. I just hated it. It could not have been a more unhappy place for me to go. Fast forward about 10 years, and as a teenager, one of my first jobs was as an orthodontic assistant. So somehow...
How did that happen? Just it was there?
You know, my boss, soon-to-be boss, my orthodontist asked me if I wanted a job, and I was available to work, and he hired me that very day, which was really fun and exciting, and I found teeth to be fascinating, and I enjoyed the braces process, so I just said yes, and that was kind of my start at roughly 16 years old. So I went on from there to be a dental hygienist, and I did that for about 10 years. And then went on to school to be a dentist and have had myofunctional therapy training along the way, which has been really, really eye-opening. With myofunctional therapy, we learn a lot about how the mouth develops and habits that can happen that will change how the mouth develops. Nasal breathing habits, it's all very fascinating about the balance of the muscles of the lips and the cheeks and the tongue. And that led me to coursework on tongue ties, which I kind of found on accident. So it was really neat. It was very fascinating. In dental school, we really I at least did not get very much education when it came to tongue ties or oral tethers at all. So it was mind-blowing to me.
So how did you stumble upon the ties?
I'm kind of a continuing education junkie, so
okay.
It's a merging of two different things. So I saw this course that was being done by a huge number of professionals. There was an ear, nose, and throat doctor, several pediatricians, some pediatric dentists, myofunctional therapists, speech therapists, body workers as chiropractors, and so many other people who were all at this one place to talk about tongue ties. So that was how I stepped into tongue tie specifically.
And so for you, I think that I remember you telling me about your daughter and the challenges that you had with nursing your first daughter. And oftentimes I think that those types of experiences lead us to our paths. So can you tell me a little bit about the link between what you chose to learn and your own personal experience with that?
You bet. So when I went to this class on tongue tie, I had no idea that there was a real life correlation in my own world. I knew I had my daughter actually while I was in dental school, and I only had about 2 weeks before I went back to school.
Oh, wow. That's so short.
Pretty short. I knew all the things that I could learn about pregnancy, and breastfeeding was one of those things where I'm like, well, this is just going to work because it always has and it always will. So why would it be any different for me? It was. So when my little one was born, breastfeeding hurt really bad. And it's one of those things where I'm like, am I being a sissy here? Is this really not a big deal? Like, why was this okay for my mom and every other female I seem to talk to? But for me, this is really horrific. I loved my kid, but boy, was she like this little piranha. You learn where the song Baby Shark came from when you have a little baby shark chewing on your nipple. So for me, breastfeeding was really, really hard. It was something I wanted to love and to enjoy. And I know the value, and I am not one to give up. And for us, we were able to. We breastfed. I would truly say I suffered through it. Because I went back to school so quickly, I had a very close relationship with my pump. So I would pump when I was driving to school. I would pump while I was at school. I would pump on my way home, and I was commuting like an hour and a half each way.
Oh my goodness!
And then I would get home and I would feed my little princess when I was there with her. So that ended up working well-ish, but nipple damage didn't go away. Pain did not go away, and so many people are like, well, the first couple days. It was a lot more than the first couple days. It was the whole time. So for me, that was really tough. But then for her, she struggled with, she was diagnosed with colic, which I kind of think is just a bucket that people put things in when they don't really know what else is going on. She also had acid reflux. And for me personally, everybody has their own opinion, and that's fine. We need to get to our opinions from our own experience. And I was told that my daughter needed medication for her acid reflux. And it was one of those things where there was really no other option that was presented. And at the time, I did not feel empowered enough to say no, even though that was very against what I felt was okay. So she was on 2 different medications for acid reflux that did absolutely nothing for her, which was really unfortunate for all parties involved. And we've learned about some negative downline effects that can happen from these medications that are being used in newborns. And, the mom guilt is just huge. All around, the mom guilt is huge. But we did ultimately, for her, learn that the root of so many of those challenges were related to her own anatomy. And because I took this class when she was older, like a toddler, it was past, we made it to a year when we were breastfeeding. And
wow, that's really far when you're
really
in pain.
Stubborn.
You should be very proud.
Well, thank you. So we pushed through, and I would not tell people to push through. That is not the solution. Like for us, we found she had speech issues. She had so many other things downline that happened as what I can only say would have been related to her own anatomy. So for me, changing from doing like traditional dentistry, walking into helping people navigate the world of these oral ties, it was a way to make a difference for other moms and babies.
And you learned this. You put 2 and 2 together when you were taking the course.
Correct.
Okay.
It was like they were going through these lists of all these different things that can happen, not saying that an oral tether is the only reason these things can happen, but this list, like, it just described my daughter completely. And
it's really, a long list. So you had a lot of things.
We had a lot of things going on, a whole lot of things going on. She's a lovely human, but boy, did she struggle through her first years. She struggled a lot. So,
And for the audience here, you'll hear, you heard me get emotional in the introduction with this. So when we talk about our children and as it's related to this, we both get a little bit emotional. And I think recently you you corrected her ties. Is that correct?
Almost a year ago. And it's been a really great process for us. So for her, there's more involved than just her tongue because she was 7 when we released her. And her anatomy is such that the roof of her mouth has grown really high and narrow, and she has more of a mouth breathing habit than a nasal breathing habit. So many of the things that kind of go hand in hand along with the tongue tie, she's already had the damages and she's made compensations for those. So our journey to get her back to as healthy as we can is more than just releasing a tongue tie. But it has changed her speech drastically. Her breathing is better. Her sleep is better. So many improvements have been made. We're just not all the way there yet.
And with your you have a second daughter, right?
I do.
Had you already been through training when you had her?
Yes.
Okay. What was the difference with her? Did she have any, if you don't mind me asking,
I got to enjoy breastfeeding.
Yep.
Like, really enjoy it. And it was great. And her mouth looked completely fine and functional.
When she was born?
She was great when she was born. I didn't need to do anything with her at all.
That's inspiring to hear.
Yes. Take heart.
That's really neat. It's so interesting also to hear about that. So
it was a very restorative experience with my youngest.
Okay. And so we're going to talk about, let's talk about what is an oral tether now.
Sure, yeah.
And what are the different kinds? Because it's not just a tongue tie.
Right.
I learned from you there's multiple different ones, multiple ties, and was very surprised to hear that, especially the cheek ones.
Absolutely. So a tie is a really just an easy-ish way to say that there's a restriction or a tether in the mouth. And we have several of them. So you'll have some people who will say there's 5, some people who will say there's 7 because they're splitting it into tops and bottoms. But you have your top lip, your bottom lip, both cheeks, and your tongue. And some people will include the lower cheeks. So those would be considered buccal or buccal, as some people would say ties. Some people will just call it a tongue tie, lip tie, cheek tie. That's perfectly fine. A tongue tie is also called ankyloglossia in medical terminology. Some people will call them TOTs, which is tethered oral tissues, and it sounds super cute, right?
TOTs for toddlers,
right? Ultimately, a tie of any of those sorts is really a variation of normal structure. We all have what's called a frenulum or a frenum, which is just a little piece or flap of tissue that connects 2 different other parts. So for your tongue, it's connecting your tongue to the bottom of your mouth or the floor of the mouth. Your lips and cheeks, it's connecting both of those to your gums. So it's like a little strand of tissue. And sometimes that can be restrictive and sometimes it can't. So there's a lot of different things to look at, whether it's stretchy or elastic or if it's moving well or if it's not, and the strength. And there's so much to look at. It's not just, oh, you look like that, therefore there's a tie. Really, in order to pay the right amount of attention to it, you've got to be paying attention to structure and and function. So anatomy and function are both equal parts.
What in terms of function do you want to pay attention to?
Sure. So breastfeeding specific, you want to make sure that those lips functionally are able to flange and flange predictably. Now, if your baby's not doing it automatically, that doesn't mean they don't have the ability. Maybe you need to teach them how. So bring the baby to the breast and flange the lips once they're on there. That's often easier to do just physically with the upper lip because there's not breast tissue in the way where you can't kind of see that lower lip. But definitely flange the lips, and if they can't maintain that flange, if that pops them off, or if you're seeing blanching or whiteness of the lips, where like right at the middle underneath the nose, that's a pretty good indicator that that tissue is being pulled inward. Oftentimes what will happen when there's a lip tie is the flange cannot happen. So you'll roll that lip out and try and get it out, and baby's going to cry, or tuck it right back under because physically that's just not comfortable for them with the amount of tension that's present. When it comes to tongue function, there's several things the tongue should do. So one thing that just really is a pet peeve of mine, people will be like, oh no, Johnny can stick his tongue out. He's totally fine. It's not tethered. Well, out is like the least important movement the tongue can make when it comes to breastfeeding. Out is great for licking a lollipop or ice cream or whatever you want to stick your tongue out for. When it comes to breastfeeding, you need to be able to elevate the tongue. So it has to be able to lift up and go up against the breast tissue and move in a wave-like motion, moving from the front to the back like a wave. And if it cannot do that, that is a functional limitation. That is when you find issues with your ability to empty the breast well, to get your supply to where you want it to be. It can be more challenging to have a positive relationship because oftentimes your jaw will compensate for what your tongue cannot do. So instead of your tongue moving in a wave-like motion, your jaw moves up and down and up and down, and that's biting you. And that is really quite uncomfortable.
So that's where the biting comes from.
That's where the biting comes from. Yep.
Okay. So interesting. And so those are two things that we know, like with the tongue and the lip. So lip not flanging or tongue not being able to go up.
Correct.
Those are two things that indicate a problem with the tether.
Yes.
Are there any other
The tongue
pretty big
should move
indicators?
in other ways as well. So it should be able to move from side to side, and you can kind of test that with your finger, just tracing along the baby's gum line. Sometimes there's body tension that will keep them from being able to do that. Not even tongue related. Can be further down line in the neck or in the jaws. So I go through several different things when I'm doing a functional test, but it's a bit more clinical.
Yeah.
I don't know how relevant that it would be to
go into it
go
in
into
depth here. Absolutely. So, so you said a little bit more clinical there. Let's actually touch a little bit on the holistic treatment or the holistic group that you bring in when you are looking at or evaluating ties and whether they're functional or, I mean, whether it's not functional or not, like functioning or not, basically. So who else do you like to have on your team?
You bet.
Not just like a dentist.
Yes, of course. So there are several really, really key players, and this is something where if you are making a call to a dentist, like first sign of pain, we don't want to do that. There are so many less invasive things that you can do to potentially get to the root of the problem that don't involve going through surgery, even if it's a minimally invasive surgery. So the first two people that I would want you to see 100% of the time, and truly, even if you're not breastfeeding, a lactation consultant is a key player because they're going to be able to check on that function that we were just talking about. So they can tell, is baby fatiguing because they're overworking other muscles instead of using their tongue? Like they can see other things that could be going on in the mouth and throughout the rest of the body. So a lactation consultant is just worth their weight in gold. In addition to lactation consultants, there are body workers. In the community here in Colorado Springs, what I work with the most are craniosacral therapists and chiropractors who are trained in craniosacral therapy. Both of those are working on unwinding tension. And if you think about it, when in utero, you've got this little baby who's curled up in a little ball, and they get out and they have these like limitless, no boundaries. They can move wherever they want to move to the ability that a newborn can. But if you have this baby who's born and their cheeks are up into their chin or their head's only turning one direction, there's so much tension. Birth is hard and beautiful and amazing, but it's still trauma. It's still trauma, for sure, for mom and for baby. So oftentimes we're putting pieces back together when it comes to mama, but we've got to think like the baby was on the receiving end of those contractions. That's what got the baby out. So there's quite a lot of pressure that is put on your little one as they're being born. And helping to unwind that pressure can take care of so many of these challenges that will present as if it were a tongue tie when really it might be tension in the rest of the body. So helping to unwind that is just imperative.
And so the order in which people typically will see you is lactation consultant makes a recommendation because I know they can't diagnose, but they can say, I think that there might be some tension or tether going on. And then they see the craniosacral therapist or the chiropractor that's trained in craniosacral therapy.
Yes.
And sometimes that unwinds the baby enough that there is not a necessity to see you.
Absolutely.
Okay.
So when you have these tethers, these areas in the mouth, they're attached to many other muscles. So if you're unwinding the muscles that are supporting the tissue, then the tissue moves more freely. And that can really get rid of it prevents you from doing unnecessary treatment is what it really does. So I like for you to have me as, in a sense, kind of the last person you call, really not the first person.
Yeah. And that's what we did with my personal experience, or our personal experience. I remember seeing a craniosacral therapist, and we could then get him to latch, which was amazing. And he would nurse for a little bit, which was a very big difference from the initial piece of it. And that was on, I think, day 3 or 4 of his life. But it didn't hold each time we went. And then we just decided to do an evaluation with you. And from that, we could look at the different levels. Do you want to talk a little bit about the different grades, right?
Yeah,
the different grades of the ties and just kind of what you typically would want to correct.
Absolutely. So again, I would bring it back to function and anatomy. So when you talk about seeing the craniosacral therapist and you're like, yeah, we were able to latch after that, which is huge. That's a big deal. So oftentimes when there is a true restriction in the mouth, you're going to go and have that visit with craniosacral therapy, and it's going to bring improvement for a time. So if there's underlying tissues that are pulling the body back into that tense state, those relief of the tension that was done by the craniosacral therapist is going to not be long lasting. So 3 days later, 5 days later, a week later, whatever that is that's pulling your body back to where it started is something that you would know then, okay, this is a really good indicator that there's something more going on than just overall body tension. So at that point, when somebody ends up in my office, we go through, and I always work really close in collaboration with the different lactation consultants, chiropractors, craniosacral therapists, because we all see things just a little bit, just through a different lens. So
it truly is holistic.
It really is. So having the perspective of each of those people, and I can't tell you how many times that we will get on a Zoom meeting or a phone call, and the 3 of us will sit and talk and say, hey, okay, what are we not seeing? Is there anything more that we need to know here? Like we form a team around you, and that's how you get the best success. When you're not putting all your eggs in one basket, you've got to really look at all of the different parts and pieces. So after you've done that and you land in the office with me, I would go through and do an evaluation. And I spend some time. That's often like a 2-hour appointment where we're going through and looking at everything. And I'm doing my best to rule out what other causes could possibly be contributing. And then we look and we look together, and we'll take pictures so that way you can see everything that I can see. Never, ever, ever do I want you to just take the word of a provider that says, oh, you have this. They really ought to be able to show you and explain to you what they can see, and also what that means for the immediate and then for long term as well. So tongue ties, this is kind of a tough thing, because with traditional medicine, you have these diagnostic criteria. You have grading systems, and they're universally accepted, whether you're a lactation consultant or a dentist or a medical doctor or an ear, nose, and throat doc. Like all of traditional medicine will use the same scale. We don't have that when it comes to tongue ties or lip ties.
To say, yes, do this, or no, do that.
Or even to grade it. So there are several different assessment tools that can be used, but not one that has been, this is the tool. This is how we can communicate with our other medical providers, which really takes away a lot of legitimacy
Why
in
is
the
that?
field. Well, multiple reasons, really. So tongue tie is something that we're truly not taught a whole lot about. So it used to be, like I said earlier, just considered a variation of normal, where oftentimes birth was done with a midwife. It was not like traditional Western medicine obstetric care. Richard Baxter has written a book called Tongue Tie. And in that book, he references that midwives used to keep a long fingernail. I know.
It just cracks me up. Every time I hear this, I'm like, oh, okay.
And as soon as baby was born, the midwife would look in the baby's mouth, and if there was a restriction there, they would take care of it with that lovely long fingernail, give baby to mom, and then baby could feed. So was that ideal? No, not so much. But was it at least recognition of a structure that was going to be a challenge to breastfeeding? For sure it was. So we've learned quite a bit since then, some positive, some negative. Go back to roughly 1950s, and formula was created. And when formula came around, there was suddenly less of a...
It was a Band-Aid that was created.
It was a Band-Aid.
Yeah. An important Band-Aid,
right,
yeah.
Without question. But that made it so that breastfeeding was maybe less popular, less sought after, which then led to a time where tongue ties were not being caught because you have shifted now from this midwifery model of care to more traditional obstetric care to more traditional Western medicine type education. I told you already that I had like one lecture on tongue ties, and it was basically...
It's kind of like nutrition for doctors.
Yes,
yeah.
absolutely.
I'm always amazed at that.
Mm-hmm. So we refer them out, and we're referring them to somebody who has that much education as well. So it's a tough thing. There's just not been a high level of importance in treating this very focused area.
And you can't do a placebo. You can't do a placebo like
Right.
level 1 study on a tongue tie because you either have one or you don't have one.
Right. And it is not a black and white. This having one or not having one is like, do I have a leg or do I not have a leg? Well, you can see that, but
because some people can function with it and some cannot.
Absolutely. Some people can function, some people can't. And it really just depends on how restrictive that is. You said nutrition. So with nutrition, there's not one diet, one particular style of eating that is appropriate for every person. Well, guess what? There's not one type of oral tether or oral frenulum that is going to be appropriate for every person. So we have to see what each person is capable of working with after ruling out the other challenges. So there are many different classification systems to answer that question, but not one that is universally accepted, which means that when I'm writing to your pediatrician and I'm saying, well, here you go, I found a class 3 or a grade 4 or whatever I'm finding, oftentimes that's more focused on anatomy and less focused on function. So I can have grade 2, which would be considered less severe or more of a posterior tie, farther back on the tongue. That is way more restrictive than some class 4s, which are like to the very tip of the tongue, but they're really elastic and stretchy. So each person has to be seen as their own person with their own function.
And again, why the importance, or I'm just going to harp on the importance of the whole team.
Yes,
there.
Absolutely.
So why are there so many different opinions around this? This comes up a lot, I think, of like, well, my doctor says this, or she says that, or he says that.
Yes. I think that really goes back to we only know what we're taught. And when we get out of school with whatever fancy degree or certification we get out with, we kind of think we know a whole lot. And oftentimes we just know enough to be dangerous. So when you really get in and you dig into this, like I've taken ridiculous numbers of hours of courses on this tiny little soft tissue that most people don't even pay attention to. So a lot of the opinions that, well, I wouldn't say that I have our opinions. This very much is evidence-based. There's experience. There's lots of collaboration amongst professionals, but they're all people who are very focused on appropriately treating restrictions in the mouth. So most people don't have the exposure. So I will not ever really truly fault another provider, because you go back 10 years ago, I didn't know what was going on in my own kid. I'd spent since I was 16 years old in people's mouths, and I didn't know. So talk about a slice of humble pie. That is what that is right there.
I think that makes you so special, though, as a provider, too, of like being able to take that with humility and being able to take what you learned and then apply it later on. I think that's the coolest thing when healthcare practitioners can like add that into their repertoire too.
It's quite the aha moment.
Yeah.
Makes it pretty real. So ultimately, I would just tell you that the education is not standard. So it's not something that everybody learns about. And it's really easy to brush something off when you don't feel like it would be a big deal. Mm-hmm. You see ear, nose, and throat doctors, and they are dealing with cleft lips and cleft palates and so many, really far more, I don't want to say far more impactful things than an oral restriction. Mm-hmm. So it does not make it to the top of the priority list. Also, it's something that's not terribly financially productive for people. So to take the time and the effort to really truly learn and become an expert in that area, it's not going to make you millions. It's it's a labor of love. Love. It's a labor of love.
Yeah. And while we're on the topic of that, you spend a couple hours with the parents.
Yes.
And then there's a follow-up appointment week 1.
Yes.
Remind me of what your schedule looks like.
So
basically.
if I have somebody who wants to come in and they just want an assessment, just have me spend the couple minutes to look in their baby's mouth, I'm actually scheduling an hour and a half, because in that time I really want to unpack the journey that has got them to my office. And sometimes that starts with, we had years of fertility issues, or sometimes that starts with a really traumatic birth, or sometimes that starts with, with my last child, I couldn't breastfeed. You have to see, where are people coming in at a really, really personal level? Because if you're looking through the lens of loss or inability to feed, it changes fundamentally how you're going to approach breastfeeding this time around. That, I think, is really the most important part of what I do, is just hear your story and honor that before looking in your baby's mouth. That should be really kind of not the first thing that we do. We need to know who you are before we know what we're dealing with. So once we look in the mouth, then, like I said, we're gonna do the evaluation, and I'll go through and talk you through everything. So if you just came in to have me look at your child, that's what we're gonna do. But we'll hear what got you here first. And then at that point, you have the option to move forward with treatment or to not. If it's just that hour and a half appointment, we don't move forward with treatment. We talk and we unpack things, and then if you choose to move forward at a later date, I schedule another hour and a half at that point. And we go through, there are exercises that are done. As many people know, this is also a point of argument.
I was going to say, yeah, that's a differing opinion as well.
Yes, it is. Absolutely. So in my practice, there are exercises that are done to help guide that new frenulum to be where it ideally should be.
It's like teaching the mouth how the mouth works too. It's similar to, you said, sometimes a baby has the functionality, but they don't know how to lift their lip.
Absolutely.
You have to train.
Yes. Mm-hmm. We call it suck training, and it's really kind of like the physical therapy for your mouth, and doing that in a way that works with the reflexes that these babies already have in place. So it's just helping to integrate those reflexes. So we do an hour and a half for the evaluation. If you've already worked with everybody, which in order to even come in and have the appointment, that's what we're doing, and you want to move forward with treatment, you're really confident you've ruled out every other cause, then we can schedule 2 hours to do everything. And then I see you again at 1 week post-op, and at a minimum, again at 4 weeks. Oftentimes, I'll see you at 1 week, and if there's been any kind of reattachment or regrowth or too fast of healing that's happened in that first week, I'll see you again at 2 weeks, and maybe again at 3 weeks, and again at 4 and 6 weeks. So there's a lot of follow-up, because I tell people all the time, I have the easy job of releasing the tissues. That's not a hard. Technically, it's not terribly challenging. You have the hard job of getting in that sweet baby's mouth and doing these exercises often and helping them to heal the right way. So being there to help you and monitor how that's going is a really, really important part of it.
And then you're checking, I mean, Jessika is checking in with you on a regular basis via messaging as well.
Yes. I always check in the night of and the next day and the third day and then every week thereafter. It's a big adjustment. That first week can be pretty raw and hard and challenging emotionally. Not to mention, you've got all these different hormones going on and you're trying to figure out which way is up and you're doing it all on like 0 hours of sleep. So being able to
especially when they're newborns, when they're little. Well,
absolutely.
I mean, you also, when they're older too, if you're doing the stretches diligently, you aren't sleeping as often as well.
That is true as well. Mm-hmm. At certain ages, the stretches become different.
Yeah.
So as a child,
and kind of
or
they
as
can
an
do
adult,
them themselves to an
for
extent
sure.
too.
Yes, absolutely, which is glorious.
And so, is there anything else you want to add about the treatment or what you do following up?
So basically, I want to be able to just walk alongside you. I have kind of a pretty unique, where it's just a chapter of life that I'm a part of. I'm not like somebody who you're going to get your teeth cleaned or get a filling or do traditional work. So I have this little window of time, and I want to give you every bit of knowledge that I think would be helpful, which for some families is more than enough. 2 hours of me talking is a long time, but it's a communication all throughout. So at that last visit, we're talking about lots of different things. We're talking about nutrition and transition to solid foods whenever that might happen, because that might be a year down the road. But if I don't talk about it, then you might transition to purees, or you might not know things that developmentally would not be the best thing. Mm-hmm. So we want to talk about oral hygiene and when teeth are going to come in and how to take care of them and what teething looks like. And it's more than just, hey, come on in and I'll clip your tongue.
Yeah, you're giving them the follow-up for how to continue the development of the mouth in the correct way.
Yes.
Very cool. Speaking of that, so when you've evaluated someone and they anatomically match, they've done the other holistic treatment, but they also are functionally matching the need for a release. Can you tell me a little bit about how the experience differs for like babies versus children and adults, and how you know?
Sure.
For the different ages. It doesn't even have to be children necessarily, just adults though.
Yeah.
I guess children are probably in there with speech and stuff.
Yeah, absolutely. So what the actual treatment looks like in my office is fairly similar. As a newborn or an infant, you haven't made a whole lot of or developed these compensations that we do develop as children and adults. So the release with a newborn or an infant, in order to be functional, is often not as deep of a release as you're getting to the right depth. I don't want to make that sound incorrect, because it is a deep enough release. But as an adult, sometimes you're actually having to go even deeper than what you would have to do with a newborn or infant.
I kind of think about it energetically as well. They have more, like as you get older, you're carrying more things like burden.
Yes.
And trauma even, tightness in your body.
Yes, absolutely. So I would 100% agree with you there. There's also a difference in how people will approach treatment. In my office, I use a CO2 laser. It's called a light scalpel. What that does, the CO2 lasers are attracted to water molecules. And we are largely made up of water molecules. So on a cellular level, it's taking that water molecule and turning it into steam or vaporizing on a cellular level. It's super precise. It's very, very safe. It's something with like a tongue release typically takes like 3 to 5 seconds for a baby. Lips generally take a little bit longer, where you might be looking at 5, even upwards of 10 seconds, but still very fast. Many people truly don't use that particular laser. It's very specific. It's only for soft tissue. There are a certain number of uses for it, and it doesn't necessarily make the most sense for somebody in a traditional office to have this tool, because it doesn't have all the uses that some other things do. Common other lasers are diode lasers, and that's what most dental offices have.
I didn't realize that there were different types of lasers.
Yes.
That probably went over my head.
Yes.
Okay.
There are lots of lasers. And it really, truly, so many people don't realize that. So you're calling up a dental office and you're screening and you're like, I'm doing a good job. I'm making
Do you
sure
laser
I'm-"
or clip, basically, is
Right.
what a lot of people
Exactly.
ask. Okay.
But there's hard tissue lasers. There's soft tissue lasers. There's lasers that generate a lot of heat and some that generate very little. The CO2 generates the least heat.
Okay.
The diode, like I was just talking about, generates a ton of heat where you can get up to 1,000 degrees Celsius.
So it's almost like a burn.
Oh, what very, very much.
It
It's
is a
like
burn.
It
Yeah,
is.
okay.
Without question, it's a burn.
Just didn't want to say it in case I was wrong.
It is. The diode also takes a lot longer. So it's not really truly laser technology that's being used. It's heat that's being used. Mm-hmm. It's a glass tip on a laser handpiece that has to be activated to get hot. So you're rubbing it against something that's dark, and then you're going through and you're releasing. And what can take seconds with a CO2 laser takes minutes with a diode laser. And you get a lot more damage. You can get a lot more damage because that heat goes through to other tissues. And we're really close to things like saliva glands and nerves and blood vessels. So for me, in my hands, I really prefer the CO2 laser. I've had really great success with it, and I find that it tends to be the most gentle and by far the most appropriate laser for infants. For adults and children, you'll find, well, even for newborns, in some places they'll use a scissor, like a surgical scissor, not like your Fiskars on the kitchen
Which is
counter.
what they call clipping.
Right.
Okay.
Surgical scissor, or even a scalpel. When you're using those tools, they tend to be not to the depth that's necessary, where you're just getting the very tip of the tie or the restriction. So this is something that's often used when the tie goes so far forward that it's almost to the tip of the tongue or to the tip of the tongue. And you can just see that webbing there and you release that, but you're not getting back to the full depth of what that frenulum had. Because it's too dangerous to do that with a bladed instrument in a child who's moving.
Yep.
So if you're going and you're seeing an ENT who's maybe using a bladed instrument, oftentimes they'll use sedation, like general anesthetic, where your child is not awake, which introduces
some additional risks.
Some definite
and
additional
other
risks.
side
Yes.
effects.
Yes. So at that point, I mean, if you had other things going on, you've got to weigh the benefits and the risks of each. So if you're looking at a child with tonsils and adenoids that are infected, and they need to get their tonsils and adenoids out, and while you're there, you're going to go through and take care of the tongue or the lip or the cheek or whatnot, well, then maybe that would be an appropriate risk to benefit option. But if we're looking at a tongue tie, a procedure that can be taken care of in the matter of seconds, general anesthesia seems a bit...
Especially for a newborn.
over the top. Yes. Yes.
Yeah. Especially for
in my opinion. So everybody gets to choose what is right for them. But for me, that is a higher risk level than what I'm comfortable taking for my own family or my own kids.
And so that's the difference between them. And so asking those questions and doing your research with who you're looking at, choosing.
That's the difference in the technique that you would use to release the tissue. The differences in what you might notice when it comes to babies versus children and adults, that's a very long list. So I'm just going to kind of read through them a little bit.
Is this on your website as well?
You know, some of it is. Okay. Yes, not in these exact same words, but this is all information that is pretty readily available. So for the infants, it's oftentimes you're looking at a lot of pain for mom oftentimes, but not all the time because like I said, it's not nutrition is one size fits all, nor are these oral restrictions and the implications that they have. So often but not always there's pain for mom and nipple damage for mom. Often but not always there are issues that are really prevalent and common in the babies. Where they're sliding or popping off, their latch is really shallow, their lips tucking under, they might be snoring or breathing through their mouth more. We really should be breathing through our nose. We are considered obligate nasal breathers. Breathing through the mouth is really detrimental for a whole list of reasons that we'll actually get onto here too soon. The milk might leak quite a lot while they're feeding. They might be diagnosed just like my daughter was with colic. They might spit up an awful lot or have acid reflux. They could gag or choke or cough when they're feeding. Frequent hiccups, being visibly frustrated while you're at the breast, being really gassy, having slow or poor weight gain, being really noisy like smacky eaters that are kind of popping on and off, and sleeping poorly. I know some of that is newborn stuff. So
that can also be the nose breathing.
Absolutely,
aspect
it can.
Of it.
Absolutely. The little lip blisters, the white-coated tongue. Some people call it a milk tongue. That's another one where it'll commonly be misdiagnosed as thrush when it's not thrush at all. It's just a milk layer that's not being cleaned off because you're not having the proper functional movement to get it up to the roof of the mouth to clean the tongue off and get that nice pink tongue. Sometimes the tongue can be shaped like a heart. You can have a jaw that's really recessed or set back, open mouth posture, a roof of the mouth that becomes really high and narrow. And sometimes you can see a dip in supply or a supply for mom that never really got up to where it needed to be. So if your supply is doing great in the beginning when it's that hormone-driven supply, and then you hit like 3 months, 4 months, and suddenly your supply is dwindling and your baby's weight is not increasing like it's supposed to, that's a time frame when your body is going from a hormone-driven supply to more of a supply and demand. And if that demand isn't able to be made by the baby, then your body's going to respond appropriately for the stimulus that it's given. So if the baby has a weak suck and it's not able to extract milk well and empty you well, then that supply often will decrease.
So if you get to that point in time and your lactation consultant isn't recommending craniosacral work or seeing you, it's time to rethink the lactation consultant as well, potentially, or just start doing that as on your own too. Okay.
I would say so.
I hear that a lot.
Yes.
They're like, I'm working with a lactation consultant. I'm like, great.
Yes.
Are you getting anywhere?
Sure. And, sometimes, lactation consultants, you touched on this earlier, where they're not allowed to diagnose a tongue tie or a lip tie. That doesn't mean they can't see it. But sometimes for these lactation consultants, their job is on the line. And if they were to say that or even suggest you go and you have an evaluation done by somebody, they could quite literally lose their job. So you've got to look at it from all the different perspectives.
Mm-hmm.
Like we all come with our own challenges
in the
here.
right way. Yep.
Yes,
understandable. Okay.
So those are kind of some of the newborn things, the infant things that you might notice. When we get to children, we can run into a increased risk for cavities, space between the front teeth. Some stunted growth can happen, an open mouth posture, and that is that's like my big warning sign. Everything that I do, I want to be able to prevent breathing through the mouth.
When little kids are hanging out like this, I'm doing an open mouth.
Yes.
I'm like, okay.
Yes.
Just like it's that stare that you think of when they look at TV.
Right.
And if they have their mouth open while they're watching TV, my thought process goes to, okay, there's a reason why.
Yes. There sure is. There absolutely is. And so many times people are like, oh, look, they're so cute with their little mouth. Oh, my gosh. I'm like, they are so cute. And that's not. So oftentimes these kiddos are picky eaters as well. So textures can be really hard. When you breathe through your mouth, you often get more of this really high, narrow palate or roof of the mouth. And when you have that, things get stuck there. So think about having a spoon of nut butter or peanut butter and getting that stuck in the roof of your mouth, or refried beans or mashed potatoes. Those are textures that can really easily get stuck in the palate. And if your tongue can't get up there and reach it, well, you're not going to want to eat that food.
I'm just thinking, sorry, husband, Tony here, but I'm thinking about, because he will talk about things that he didn't like as a child. Yes. And we know he's tied. Sorry, Tony. But yeah, and you just saying this now, we know he didn't like these things as a child either.
Right.
And he'll eat them now,
he's
but
telling
oh my
you something.
Gosh, yeah.
Just like these little babies are trying to tell you something.
So interesting.
Absolutely. Other things that can be really hard for people with tongue ties, kids, adults, are solid foods like lean meats. So think of your grilled chicken breast. Nutritionally dense, sure. Hard to eat, sure. So if you have this grilled chicken breast and you go and you cut it up and you're chewing and you're chewing and you're chewing, when you're tied, oftentimes you chew on one side. So if you ever go on a farm and you're watching a cow eat, they just chew up and down, up and down. We should be moving back and forth and up and down, left and right, all over the place. When the tongue is restricted, it's not guiding the food to the other sides of the mouth and helping you really chew that food well. So you'll get these kids who are wanting to eat the chicken that you're putting in front of them, but they've got to dip it in the ranch dip or the ketchup, or drink multiple glasses of water or milk when they're having their meals because their mouth isn't processing that food the way that it needs to be processed to effectively eat it.
And even, I mean, it's a saliva movement too,
Absolutely.
is what I'm hearing.
Absolutely.
I mean, you can all take a minute here to move your tongue and see how much saliva you create. It's pretty amazing.
It is, yes. Absolutely. And when the tongue is restricted, that restriction often goes right through the little bump underneath your tongue that I call it your gleeker. So if you ever like yawn and spit comes flying out of your mouth, that's your little gleeker. That's not the technical term. But that is a really active saliva gland. And when you're tethered, you often don't have as much saliva, be it from mouth breathing or from really kind of trapping that saliva gland. So all that to say, picky eaters are really common in a tongue-tied community. And then gagging and choking while you're eating. So if you think of that lean meat that you're going and you're trying to swallow, but it hasn't been chewed up very well, and you get to the back of your mouth and suddenly it comes right back out because you have it's eliciting the gag response because it hasn't been chewed well, so it's bigger. But also, the roof of your mouth isn't used to having that kind of stimulation. And when that's the case, anything that gets there, you're going to have a hypersensitive response to. So whether that's a baby that's kind of choking on a pacifier or a strong letdown, or a child or an adult that can't handle swallowing pills or having different foods that reach back there. Oftentimes these kiddos can be really slow eaters. They may have delayed speech or speech challenges, things like kitty cat is titty tat and I willy love you, and those things that we all think are really adorable. But when you hit 7 years old, 8 years old, those things are not adorable anymore, and they are also not developmentally where you should be.
And that's not saying this for a 2-year-old. That's saying
Correct.
this for, there are different, and you can look this up online, but there are different syllables that are milestones to be met at different ages.
Absolutely. So 3-year-olds, like 90% of 3-year-olds should be able to articulate the sounds of M and N, H, W, P. You hit 4 years old and there's different letters that come in, D's and B's, K's, G's, F's, T's. R's and L's, those don't come in for 90% of kids until you hit 6 and 7 years old. And then more sophisticated sounds like blends, like th. Those are things that happen around to age 8. So knowing that, okay, my kid can't make this sound, but maybe it's appropriate for your 2-year-old to say titty tat until they're 4.
Mm-hmm. Yeah.
Oral habits are really common in children also, where they might suck their thumb or suck their finger or a pacifier for extended periods of time. And one reason that happens is there's a little bump behind your 2 front teeth. I don't know if you can feel it. It's on the inside. If you go back and forth, there's a little bump there, and that little bump is a nerve bundle. And when you put pressure on that little bump, you're helping to regulate your nervous system. So ideally, your tongue goes there because your mouth is closed, and that's where your tongue is supposed to go. But if your tongue doesn't go there, putting something else in the place is going to give you that same soothing, that same calming effect for your central nervous system. So that might be a thumb or a pacifier or hair or a sweater or a blanket.
And that's top or bottom?
Top.
Mm-hmm. Well, that's good.
Yeah.
I mean, for everyone to know, that's a good, quick nervous system. Is that a vagus nerve reset? I don't know. I have to look into that.
Yeah.
In a sense,
yeah,
it is. Okay.
Absolutely. So
interesting.
Yes. And then other things that you might notice as a child are crowded teeth. If you are looking at your 2-year-old, your 3-year-old, and their teeth look perfect and they're nice and together, that is a crowded mouth. With our kids, our toddlers, we want to see spaces between their teeth. When there's not space, that's a really good indicator that their mouth is going to be crowded, that you'll be getting to know your orthodontist really well in the future. The spaces are important because as a child, you get 20 teeth, and as an adult, you get 32 teeth, and they've got to fit in the same mouth. So if you can't fit those 32 teeth in your 20-tooth mouth, we need to grow your mouth, and ideally, your tongue is doing that growth, which happens so early in life. When I was talking about purees, We want the mouth to work. We want the tongue to move. The muscles guide the growth of the bone. And when that happens, you have a mouth that's big enough for teeth. It's not an accident that we got wisdom teeth. Like that's not
We're
something
meant to have them
right.
still.
Precisely. So when we just think that braces and wisdom tooth extractions are just this rite of passage that we all should do, that's not okay. There's
other things you can do to expand the palate later on.
Absolutely.
It's just more challenging when you're
Yes.
older.
Correct. Yes, that's absolutely accurate. So additional things you might notice with kids are restlessness or swollen tonsils and adenoids, frequent ear infections, difficulty focusing. There are studies that show a correlation between mouth breathing and a lower IQ, which that one really gets me. When you want to talk about mom guilt, that one, for me, I'm like, what did I do to my daughter? I didn't fix her until she was 7. How much more potential could we have had? But we've got to let that go.
She's still so young.
She is.
I mean,
She
I've
is.
seen other studies about how kids really hit their thing around 12. It's like an equilibrium point around 12 years old. So
That's what we're holding out for,
Yep.
my friend. They might clench or grind their teeth. You might also find bedwetting that happens. This is a really common symptom of sleep apnea, where your body is doing smart things because your body wants to be alive. So when you're sleeping, if you're not breathing through your nose and you're snoring and your mouth is open, you're not getting enough oxygen to your brain, to your body. So your body wakes you up by wetting the bed. And that's a kiddo who might be very well potty trained. You could be talking about 7, 8, 9, 10, 11, 12-year-old who's still wetting the bed. But that's really just their body saying, please help me. The acid reflux and GERD issues can continue. There can be a higher risk for things like asthma and allergies, constipation. Many behaviors like ADD and ADHD, behaviors that are exhibited by those that are diagnosed with ADD and ADHD are often seen in a population that is tongue-tied, but that is not saying
Also,
there's a
like,
direct correlation there. Or
mouth breathing, nose breathing,
exactly.
same thing.
That's what it comes down to. So you're
which
not,
comes like a really a whole like myofunctional analysis.
Absolutely, yes,
of it.
Absolutely. And then poor performance at school. So that's my very long list for children, and that does not mean all of these things are because of a tongue tie. There are other reasons. So with the babies, we're seeing lactation, we're seeing body workers, we're ruling out the other possible causes for these big, long symptom lists. And this is not meant to be scary. It's really meant to be like guideposts where you can look and say, just like I did at the course that I went to where I first learned about this is, oh, wow, what have I missed? So let that be more of a key, a help, and not something that is there to cause fear, because that is not what this is about. In an adult, there's a list as well. So oftentimes I'll be looking at babies, and then mom and dad are like, well, but wait, what about us? Is it my fault? Is it his fault? And of course, the parents have already placed bets on whose fault it is.
I'm like, lift up your tongue.
Right.
It was like, you hurt your mom.
Yes, that's right. Yes.
Yeah.
So for adults, those speech difficulties might continue throughout life. You might have years in speech therapy where you've maybe perfected the sound, but at what cost? So oftentimes there are really big compensations that are made when you are able to make the sound, but you're using other muscles to be able to make that sound. There's a lot of oftentimes neck and shoulder pain and tension where you have this forward shoulder posture, forward head posture that puts so much extra strain on your neck. Yes, do that as you lean your head backwards.
Like
Doesn't that feel
stretch your
good?
throat chakra.
Yes. Oftentimes these adults will have a lot of pain, like TMJ pain and clicking and popping in their jaw joints, tension headaches, migraine headaches, the strong gag reflex like we were talking about with taking pills, or maybe it's when you brush your tongue or use a tongue scraper. That open mouth posture that might have been cute as a newborn, you thought that is not cute as a 40-year-old. Crowded teeth. And sometimes those crowded teeth are in people who have had braces, and sometimes 2 and 3 times, but you didn't address the root cause.
Yeah,
I am of the very strong opinion that every orthodontic case should have myofunctional therapy, because if you don't train the tongue and the lips and the cheeks to do what they should, your teeth are just like, they're just like little sailboats, and they're going to go whatever direction the wind is blowing. And when it's a fight between the lips and the cheeks and the tongue, that's what happens. The teeth move back to where they started because that's where you're moving them. You can have jaws that don't line up well, where you're really set back. I talk about mask memes when I'm in the office, where you have these people that are like gorgeous from the forehead to the nose bridge, and then they take their mask down and you're like, oh, well, what happened there? It's the jaws don't form properly when the tongue isn't guiding that growth, and that growth happens early. So by 2 years old, you're already half grown in your jaw, your whole lower half of your face. And by 4, you're close to 80. You're between 75 and 80% grown.
That's why people trained in myofunctional therapy talk about, if you can, nursing until 4.
Yes, absolutely.
Interesting.
Sleep apnea is another big warning sign of, of not properly functioning musculature. And at the root of that might be a tongue tie. And hyperactivity or inactivity, like I was briefly touching on with ADD, ADHD, that is kind of like with bedwetting. It's how your body is responding appropriately to the stimulus it's given. And when it's deprived of oxygen, your body is going to focus its energy on doing what's necessary to keep you alive. And can you be alive and have ADD? For sure you can. Can you be alive and have anxiety? Well, just look around, my friend. You sure can. So your body is going to focus on what it needs to be able to keep on living, and sometimes that's at the cost of our mental health and behavior. Constipation can be a challenge as well. Waking easily or often throughout the night, being really tired or unrefreshed in the morning. It's common to have sinus infections, frequent sinus infections. When your jaws don't grow the way that they're supposed to, they are smaller, and the sinuses that sit above those jaw bones are smaller also. So it takes way less fluid accumulation to build up to create that sinus infection just because they're smaller. Oftentimes, these people will also have a deviated septum in their nose, and that's a result of the palate. So the roof of the mouth is the floor of the nose, and when the roof of the mouth is high and narrow due to lack of stimulation from the tongue, from swallowing, which we do like 2,000 times a day, and when you do that right, it's putting pressure on the palate and growing it broader and wider and further forward. But that doesn't happen if your tongue doesn't reach the roof of your mouth. So that nasal septum deviation, and then the clenching and grinding of the teeth, snoring, most of those things we've already talked about. Another fun thing, as I work with children and adults, I've had some cases recently where I had multiple people who had tinnitus or ringing of the ears. And when they were released, the ringing is gone. I had another, a person who I just like very much, who happens to be a medical doctor. And his wife is a body worker, and he found that when his wife would do mouth work on him, specifically under his tongue, that the pain he has in his feet would go away. So like plantar fasciitis and Achilles tendon pain, yes, would go away. But when she was done, that would return. So we talked, and he's like, Jess, what do you think? Should we see what happens here? And we did, and that pain has now gone away. So your tongue is a part of this fascia system called the deep front line. And that goes from your tongue down your throat. It extends all the way down to your toes, but it's wrapping through your diaphragm and the pericardium, which surrounds your heart, all down like the psoas muscles, down your legs, all the way to your toes. So there can be downline effects of tongue tie.
So interesting. I mean, you're saying pericardium, even like heart attacks and like the pressure. Oh my!
And your
goodness.
lungs and your ability to breathe. Like so many people notice a pretty substantial difference in how it feels when they breathe. And I mean, there's not much more important for life than breathing. Mm-hmm. Yes. So it's wild and fascinating to learn about how deeply everything is truly connected.
And this is where you can also give an amazing gift to your children.
Sure. If
you notice this when they're newborns or they're younger.
Yes.
I mean, even when you're older.
Yes.
It's a great gift you can give to yourself then.
Absolutely.
But if you are informed of the benefits to doing this body work, or in the case of needing a correction.
Yes.
And also, like, the risks of it too, of like, I mean, it's a surgical procedure to an extent, and the different, the different types of lasers, and you make an informed decision using your brain. We talk about that a lot here, like benefits, risks, alternatives, intuition, and sometimes doing nothing.
Right.
Yep.
And sometimes that's the best thing.
Yeah, that's the best thing that you can do. But you can give this amazing gift, and then they don't have to have these symptoms down the line either.
Absolutely.
And we have that knowledge now that we didn't have, like you said, 10 years ago even.
Yes.
And it is becoming more common to hear about it.
It is. It's gaining popularity, certainly, as breastfeeding has become more of a norm now.
Again,
Yes, exactly. It's back in style, y'all. It's a win.
Yeah.
But as that becomes more important, you're having some really key people who are doing really high-quality research, and really they're just at the forefront of they're at the front lines. They're trying to fight for better knowledge and better acceptance and understanding of these tissues and how much of a role they really do play in life. So it's great. Like we're on our way. It's a slow boat, but we are on our way.
And speaking of that research that you're like you were talking about, do you have any idea, based off of any of the studies that you've come by, on what causes tongue ties or how to prevent it?
So that is the
it's a loaded question,
day.
and I know that this is, again, one of those things that's a little bit, controversial to an extent, but I'd love to hear your thoughts around it.
Of course, yeah, absolutely. So the tongue is one of the very first things in our body to form.
By like 12 weeks. I mean, it's formed, but then they start learning to suck and swallow at 12 weeks.
Yes, absolutely. So your amniotic fluid is being swallowed at that point. But even before that, to have the tongue form, the formation of the tongue starts at 4 weeks gestation.
So your preconception, I'm just saying, like, your preconception health does matter to an extent. Yeah.
Yes. And that's the bottom line of what I'm going to tell you here. But at 4 weeks, you oftentimes have no idea you're pregnant. So you want to enter pregnancy in as healthy of a place as you can. So working with someone who is skilled in nutrition, working with functional medicine, preconception and throughout. There have been studies that are being done on cause. So ultimately, when a tongue tie or a lip tie, these midline defects happen, it is in utero a result of the body not going through and breaking down that tissue when it was supposed to. There's a cellular process called apoptosis. That's something that did not happen in that particular area. There are studies being done on correlation between tongue tie and the use of folic acid. And folic acid is something that is like one of the key ingredients in our prenatal vitamins.
Most prenatals, yes.
Right. Mm-hmm. So that folic acid can come in different forms. It can be in an activated form. It can be a methylated folate, or it could be a synthetic folic acid.
Mm-hmm. Which folic acid is the synthetic form. Folate is the activated form, and ideally methylated folate is what your body needs to be able to absorb it.
Absolutely. So when you're on a prenatal vitamin that has a synthetic that has folic acid.
I just say throw it away, but
yeah,
that's what I say, but get the folate one.
There are studies that show an increase in prevalence of tongue ties and midline defects with the use of folic acid. Now, folic acid or specifically, ideally, methylated folate, that's something that is given to you to prevent midline defects, things like spina bifida. But guess what a tongue tie is and what a lip tie is? Well, that's a midline defect too. So the study that I'm referencing, it found that there's an overclosure that will happen of these midline structures, leading to a tighter closure of things like tongue ties and lip ties. And that is, it correlates to how much and how often that particular form was used. And then you get into like the kind of sticky territory of things like MTHFR mutations and the buildup of toxins that will happen and the difficulty in metabolizing some of these things. So having too much or too little, it's very impactful in your baby's health, maybe even before you knew there was a baby there.
Mm-hmm. Yeah, it's really interesting to me as I started digging and just in my training as well, learning about the difference between folic acid and folate, one being synthetic. And in most prenatals, and I've mentioned this before in other podcasts, if you have a prescription prenatal, just throw it out and find another one. Whole foods-based ones are the best because that's where you're going to find the highest quality form of folate or methylated folate. And also, like Jessika mentioned, there's this balance. You can have too little, but you can also have too much.
Absolutely.
And I know in my case specifically, I actually was high in my folate when I tested it, postpartum even, because I had been pushing to take a lot of it because I knew that I had one type of mutation. It wasn't the one that was significant, but I also knew I need this for my baby, right. And I knew that I had been deficient in it based off of some other things.
Sure.
So this time around, it's very, very different. I was making sure it was in the balanced region. And there's always studies coming out on different things as well. And
absolutely.
There's other
you had talked to me
nutrition.
About vitamin A and if there could be any correlation there. So, this is another reason collaboration is so important because vitamin A, that hasn't even blipped my radar.
Mm-hmm. Yeah, and vitamin A, again, there's a synthetic form of it and there's a food-based form of it. And there's difference between meat food-based versus vegetable food-based. And then again, the correlation be for other midline defects, which people, like you mentioned this earlier in the podcast, people don't always think about the ties.
Right.
Yeah, that's
absolutely.
kind of the last thing that they think about.
Sure.
Because it seems so minuscule, but
right.
as we know, it can be impactful to so many different things.
Absolutely.
So we talked about, around this, potentially preventing it can be done through nutrition, having good preconception, but also pregnancy health as well. But also, do you think there's a genetic component to it?
Yeah, there has been shown to be a genetic component. So many times families will come in and every single week this happens. Well, no, it's just the Smith family. It's how we all look. We all have the space, or we all have the heart-shaped tongue. And then it's right. But why?
And then I think about the Weston A. Price Foundation
yes.
and the ancestral diet
yes.
and the tribal diet too. Their mouths were wider.
Absolutely.
We didn't see these issues. They're not eating the things that we now
right.
eat today.
Yes.
And you hear about generations that have been following that have successfully expanded their mouths,
yes.
which is really cool.
Yes,
to see that, and then knowing that you can have that impact on your child, and then their generations to come if you teach them and
yes.
do these things for them too.
These changes with our more civilized world, it's so detrimental, and you see it quickly. In the first generation, you're seeing large percentage changes, and then you go to 2 and 3 generations, and it's almost like those big nice skulls with the 32 teeth and the big open jaws, and no such thing as sleep apnea at that point. We've done this to ourselves. It's not just genetic, it's epigenetic. This is something that it is all around us, and it's a choice largely that we're making every single day.
Mm-hmm. And and you can also vote with your money and in where you put your money for food.
Absolutely.
And which is pretty cool. It's epigenetic in a challenging way, but you can also reverse it.
Yes.
Which is a good thing to hear. It just takes a lot of time, and you might not see
right.
it.
Yes, generations down the road. Just don't think you've got cute little mouth breathers.
Yeah. Okay, I have to ask this because this comes up all the time.
Sure.
But pacifiers and purees.
Mm-hmm. So
after, you talk about it with your clients after they've come in and, they've successfully been completed or done the release. But
yes.
What do you recommend for this?
This is such a tough one. Pacifiers, like I said earlier, they are putting pressure on that little nerve bundle behind your upper 2 front teeth, and that is helping your baby to calm down. It's also helping with their suck reflex, and that's fine for a time. That time, ideally, is no longer than the first 4 to 6 months. And I know you're saying, no, Jessika, that's ridiculous. Don't be crazy. Your tongue really, it's so important that it sits in the roof of your mouth. And when the pacifier is there, you're shaping the roof of your mouth as the pacifier. So you get this higher, more narrow palate. People will often ask me about, well, what about the orthodontic pacifiers that look like they're flattened, like an expander? Well, do you want your nipple to leave your baby's mouth flattened? I think not. So why would we want to put something in their mouth that creates this habit of that's what that's supposed to feel like? So there is one pacifier that I tell people all the time I dislike the least, meaning I don't love it, but I dislike it the least. It's called a ninny, and it's a pacifier that's shaped very much like a breast. So it's like there's an areola, there's a nipple, and it's flat on the outside. The pacifiers that are molded to your face that are often called orthodontic pacifiers, when you're sucking on that pacifier and it's putting pressure inward on your upper and lower lip and your jawbones, that's creating poor growth patterns. That's creating these set back jaws. So having a pacifier, if you choose to use one, because everybody needs a sanity button every once in a while. I get that. I certainly understand that. But that doesn't need to be like 24/7. We do not need to have pacifiers in our baby's mouth all the time. So having a pacifier that does not put pressure on the lips or on the jaws, on the cheeks externally, and then having it symmetrical all the way around and echoing the shape of your breast would be the best. So the ninny pacifier is what I would recommend.
I'm looking at that right now.
Isn't it fun?
Yeah, I mean, it's like when you're nursing, you want them to take the full like areola and
Yes.
breast in.
Yes.
So yeah, it looks like that. I mean, it's still not perfect. It's still smaller, but
right.
Yeah.
Yes. So that's
cool.
one that I will often use for some of those suck training type exercises.
Yeah.
If baby doesn't want to suck on your finger, well, she or he might say, oh yeah, this pacifier is going to do just fine. It's a different texture. It's just different. So that is a good tool. So I would tell you, use the pacifier as a tool. Don't use a pacifier that is flat. Don't use one that molds up against your face. Some of these, there's like latex ones that look like little balls now, and people love them because their baby can stick them in and they can keep them in their mouth, but they're changing the shape of the roof of the mouth, and it's not an ideal thing. And some of those little rubber ones, the latex ones, they don't put pressure on the lips, which is great, but you're not creating good oral habits. You're not creating balanced musculature. You also asked about purees. So I am a big fan of baby-led weaning, and when it comes to introducing foods to your baby, I would tell you want to do that at a time where it's developmentally appropriate. So that should be a time when your baby's able to hold their head up on their own and say...
And that means if they're 6 months and they're not doing that, it's not time for food.
Right, exactly. We're not one size fits all. You have to pay attention to what your baby's level of development is. So maybe that's 4 months. Maybe that's 6 months. Maybe that's 1. Maybe you don't want a drop of anything other than breast milk going into your baby's body until they're 1 or 2 or whatever that case might be. You've got to do what's going to be right for you and your baby. So when they're developmentally ready for food, they might be sitting on your lap as you're eating, and as you bring that fork to your mouth and they are leaning in to follow where that food is going, so they're showing interest. They're holding their head upright. At that point, I say, let them try. Let them try what you're eating. So when you were talking earlier about countries that maybe are not as, I hate to say the word.
Ancestrally, or tribes, they don't have purees.
Right. Absolutely not. So we've done this thing, just like we have microwaves, just like we have fast food, these things that are really convenient for us, but it's at a cost. Purees are convenience at a cost. Squeeze pouch foods, convenience at a cost. So it's lovely. It's lovely to be able to toss one in the back of the car and say, oh, here you go, buddy. We're on the road and I know you're hungry, but you can have this. When realistically, that is such a detriment. Having a puree-based diet for your kiddo after breastfeeding is work, and you're using so many muscles to be able to do this feat of eating. And in these ancestral tribes, you're talking about people who are living off the land, and they're eating real food. They're eating fruits and vegetables and meats, and they may or may not be processing them. They may or may not be cooking them the way that we cook them, or using utensils that we might use, or that sort of thing. So you have to continue to do the work with your jaws, with your tongue, with your cheeks. You're working those muscles out, which creates a good growth pattern, which creates mouths that let you hold 32 teeth, that don't create sleep apnea type habits and snoring. So it's so important. Purees, all you have to do is swallow them. That really does not require a large amount of skill, much like when we moved away from breastfeeding as formula was introduced. Most babies, like I said earlier, can
Bottles
take a bottle.
Easier.
Right. Purees are easier. I get that, but easy isn't always
Mm-hmm.
good. We need to work. And if we can use those muscles to really work, then we're going to grow our mouths the way that we should be growing them. So I strongly encourage baby-led weaning, where you're introducing foods when the babies are developmentally at an appropriate stage where they can take those foods. Give your kiddo a raw celery, carrot, broccoli. I have families who really love like those beef jerky sticks, not the little tube looking things, but the actual strips of beef jerky. They're going to chew on it. They're going to explore. It's hand-eye-mouth coordination. Those are valuable tools for your baby as they're developing.
And that might mean that they aren't getting the calories from the food as
Correct.
quickly as you would expect. So they might still be relying on nursing or
Absolutely.
on, if you're formula feeding, as their caloric intake.
Yes.
For that too.
Yes, without question. It's more, it's all about exploration and finding new tastes and flavors that you like. But that doesn't mean that it's an end to your breastfeeding.
It doesn't mean too, like if you're having applesauce and that's something that you're regularly going to have, they learn to eat the applesauce. But
of course.
I mean, who wants to have pureed carrots on carrots are fine, but like broccoli on a regular basis or whatever.
Right.
Snacks here and there, if you need the easy out for something, okay, great. But having that be the regular, like the majority of the diet, I can see how that can be harmful. Yeah.
Yep.
Okay. Well, Jessika, thank you so much for being on today. One last thing I want to pose to you ask to you is one, where do we find you?
Sure. So, you know where my office is here in
based
Colorado
Colorado
Springs. Yes, absolutely. I have a website. My website is www.thrivegrowco, like Colorado.com. And you can email me directly at Dr. Jessika. It's spelled silly. Sorry, y'all.
Jessika. We'll link it on here.
Dr. Jessika at ThriveGrowCO. I have a completely inactive Facebook page, so I would not recommend reaching out to me there. Social media is not my thing. My thing is one-on-one, face-to-face people time. So you're welcome to reach out to me those ways. The phone number for the office is 719-354-2472. When I see you, I give you my cell phone number. It's like really my cell phone number, and you have access to me 24/7 forever. It's not for the amount of time that I treat you and work with you. I have people who are reaching out to me years later asking me questions about toothpastes or dentists or all the different things. So I am so blessed to be able to follow you and walk with you through your whole journey, whether you have dental questions or just simple mom questions. Anything I can speak to, I'm sure going to do my best to.
Thank you for that. And if someone is not in Colorado or nearby, how do you recommend finding someone that will treat holistically? Sure,
absolutely. So there are a couple of really great institutions. One is called the Breathe Institute. That is based out of LA. And they have Sarush Zaghi is the ear, nose, and throat doctor who's there. He does a lot of training for adults and even children. Really, really good, appropriate, functional releases. That's a big thing. When I'm doing the releases on kids and adults, it's a full body thing. We're standing up, we're rolling our shoulders and our neck and moving our feet. Like, you want to have that release extend from your tongue to your whole body. So he teaches a functional approach to releases. And then Chelsea Pinto is there, and she is just a godsend when it comes to newborns and infant releases. So anybody who has been trained by the Breathe Institute, you'll find them on their website.
I'll link it.
Okay, yep. Wonderful. You can find Breathe ambassadors there. I'm listed there too, but it's a very old address, so don't go with that address. There's another great person, a dentist who has taught so many people about tongue ties. I referenced him earlier. His name's Richard Baxter. He wrote the book Tongue Tie, but he has an academy people can go through in order to gain more education, and he's going to focus also on working collaboratively with lactation and body workers when it comes to your newborns and infants. And then the particular laser that I use, the light scalpel, that is another good resource if you wanted to find a doctor who's utilizing that particular tool. So you can get a good release with any tools, depending on the hands of the provider that it's in and the training of the provider that it's in. I am of the not so subtle opinion that the CO2 laser does the most appropriate, precise, and gentle release. So Light Scalpel's website is another great place that you can go to be able to find a provider that utilizes that technology.
We will link all of these.
Awesome.
Yeah, I will get all of the information from you. While we're on that note, are there any red flags that someone should look for in a provider?
Short answer is yes. There
Okay.
are big red flags. So I can't stress enough how important it is to have a community of people around you. So having that lactation consultant, having the body workers, people who are really trained and in it for your goals, not my goals. So not everybody comes to me because they want to breastfeed.
Mm-hmm.
These can be babies that are having trouble with formula, with bottle feeding, who will refuse, who are on G-tubes.
Lack of weight gain,
absolutely.
failure to thrive.
So many different reasons. So you've got to have a team that's going to work towards your goals, somebody who's going to take the time to hear your story, because even you might not realize how much previous traumas can echo into your breastfeeding success. So having somebody who will take the time to really listen. This should not be a 15, 30-minute in and out procedure with no follow-up. So having a good tool like the CO2 laser, the light scalpel, having a team of people who will help you, having somebody who's going to walk alongside you through the whole journey and follow up with you closely throughout, who's readily available to you as you're going through this, because you're going to come up with questions, and they're common questions, but you need to have the ability to get a quick answer. Another big piece is, even if you have those key players, the lactation consultant and the body workers, if they're not all communicating, then there's things that are being missed. So making sure there's good collaboration between your team, and then having the proper stretch routine. Some people don't call it stretches because that sounds scary. You could call it wound management. Whatever you want to call it, you have to guide those tissues to heal the right way, because your body is smart and it's going to do smart things, and healing is one of those things. Babies heal really fast. So those exercises are meant to prevent the healing from going too quickly. So if you had a provider who would get you in, no questions asked, have a 30-minute visit, release you with whatever tool that they've got, and send you on your way, I am so grateful when it works. And I'm also so heartbroken when I see people come into my office after having releases that were done without being properly cared for. So finding the team who is going to work with you and do it right.
So asking the question on the process all the way from start to finish,
yes.
What that is.
Yes.
Great. Well, thank you so much for being here and spending your time today. I appreciate it so much. We will be linking everything that Jessika mentioned, including that study she mentioned on folic acid and folate as well. If you have any questions, please feel free to email her or even email us, and we can forward that along. And I hope that we will see you next time.